start the session. I'm from Eswatini Hospice at home, and we welcome everyone who have joined today, and we so appreciate your presence. Today we have a wonderful session, and for the sake of progress, we will request that we introduce our names on chat, and also those who are with us. May I request that we introduce our names? I will start with Messi. Can you introduce your name, Messi, or yourself?
Thank you, Mr. Mahlangu. Good morning, colleagues. My name is Messi Shabangu. I am with the Eswatini Hospice at Home Hub team. Thank you.
Thank you, thank you, Messi. May we have Cyprian to introduce yourself? Cyprian.
Afternoon, team. I'm Cyprian Matsenjo, Palliative Officer at the National Cancer Control Unit.
Thank you. You are joining alone today?
No, I'm with my neighbor here.
Afternoon, team. My name is Amobuhle Lukele from the National Cancer Control Unit.
You are welcome, Shanti. And Zinhle? Zinhle, are you hearing me?
Afternoon, team. My name is Zinhle. I'm Nansigelelo from RFM Palliative Care Unit.
Thank you, Zinhle. Nomatemba.
Good afternoon, team. My name is Nomatemba Gininza. I'm working under the Sexual Reproductive Health Manzini. Thank you.
Thank you so much, Nomatemba. We are grateful to have you. May I have Simpiwe Dlamini introduce yourself too?
Good morning, team. My name is Simpiwe Dlamini. I'm a nurse mentor in Georgetown. I'm supporting the Lubombo region, Good Shepherd, that side. So thank you.
Thank you so much, Mr. Dlamini, to have you. Today we are blessed. We have Dr. Diana, but he will introduce much more information. You can greet us, Doctor, maybe for this time.
Thank you very much, Mr. Mahlangu. I struggle with the pronunciation, but I think Sandil is easier.
Yeah.
So delighted to be on this forum. My name is Diana Basirika. I'm a nurse trainer at Hospice Africa, Uganda, and I work with the International Programs Department, where we support the integration of palliative care in other African countries other than Uganda. So delighted to be on this forum and take you through this session. I don't know if I have the right to share the slides, whether it's possible for me to screen share.
I wanted to
So still checking with you, Sandil. Is it possible for me to share the screen, or will you be the one to advance the slides?
Thank you so much, Doctor. I think you can share. What I can do now is just to introduce and say to the team that we have you, Dr. Diana from Hospice Africa, Uganda, who will be taking us on incident and end of dose failure pain management. I hope team will learn more and put into our practice on how best we can manage our patients, especially those who are experiencing incident and dose failure, especially when it comes to the issue of working with opioids in our different facilities. May I allow you, Doctor, to share your screen if you can, and continue with your presentation.
Thank you very much, Sandil, but I still have no right to share the screen. So if I can be assisted, that will be helpful to enable me share my screen. And just also a correction that I am not a doctor, I'm a nurse.
Oh, okay.
Yes, yes, thank you.
Okay, let me do this. Can I give you this co-host rights? Okay.
Maybe.
Right now.
Let me try. Okay, yes, that is okay then now. Okay, that should be fine.
Thank you.
Thank you. Can everybody see my screen?
Yes, we can see it, Doctor.
Okay, that is very good. Okay, thank you so much. Again, I'm very delighted and humbled to be part of this forum. Thank you so much for inviting us to be part of this forum. So as we go through this session, as Sandil has introduced, incident and end-of-life failure pain management in palliative care, I hope we can learn from each other based on the current practices in our own countries. So as I said, I work at Hospice Africa, Uganda as in the International Programs Department. Hospice Africa, Uganda, just a brief of it, is located in Uganda, mainly in the capital of the country, and we have 3 branches. Our vision is to see that palliative care is available for all those who need it in Africa. And you can get more information about our work, about what we do, by visiting that website that I've shared. We have currently impacted 37 countries from 1993, when palliative care was only known in just 3 countries. So we are now in 37 countries. So we are really proud of that and hope we can continue working with Hospice Eswatini to really advance the palliative care agenda. Our core areas are mainly those that you're seeing: patient care, training, morphine production, but also advocacy. And for all the countries that we are working with, we try as much as possible to use the kind of model we are using here in Uganda to incorporate those areas in palliative care, because when you look at the public health approach, you cannot really do without without those 4 areas. If I may ask, as we start our session on end of dose failure and then incident pain, opioids are a key factor in this management. And therefore, that makes me wonder or ask a question, if that's okay. Is oral liquid morphine available in Eswatini?
Yes, yes, we do. We do have the oral morphine, especially the MS. The fast acting one.
You have
the fast
tablets.
Both tablet.
The fast acting.
Yes, both the tablet and the liquid.
Okay, that is very good to know. Thank you very much. And it's widely distributed in the country. Is that so?
In the most preferred facilities, it does. Maybe before I step to the hotel, can you share with me the rights? I gave you all the co-host, the rights, so I made you the host. If you can share with me co-host.
That's fine. Let me do that now.
Yes.
Okay. Co-hosts. Yes.
Thank you. Then we can continue then.
Okay. So then, and it's easily accessible in the country, right? For all patients, or is it just in hospitals? Can patients access it even while they're in the community?
No, maybe the colleagues will support me, but currently in the country, you only get it in a facility. For you to get in a community, then it requires for the patient to travel to the doctor late or where there's a prescriber like doctor, because in our country, the law still allows the doctors to only prescribe morphine.
Okay, okay. Thank you so much for that insight. Okay, let's dwell into our session today. So by the end of this session, we hope that we can be able to define incident and end of dose failure pain, that we'll be able to discuss how these present, the characteristics of these two pains, but also describe their management. I would love this session to be quite interactive. I know we are limited by time, but we'll try as much as possible to be within the 45 minutes. What is incident pain? Anybody who can respond to this? What is incident pain? Any response? Cyprian, would you like to respond?
No idea, no idea.
No idea. Anybody who has an idea? It does no harm to try, because we believe that all adult responses are correct. Anybody who would like to try? What comes into your mind? Incidental pain? Zwane? Okay.
Hello. Hello.
Yes, please.
Yes, I think it's that is associated with.
Sorry, I missed out that. Anyway, just not to waste a lot of time. So incidental pain is it is transitory. It's a transitory flare of pain associated or initiated by a specific activity. So what do I mean by transitory? It's not permanent, and it comes like a flash. The way you will see a small light coming in, it's a flash and it's not permanent, it is short-lived, and it is usually associated to a certain activity. That's why we are calling it incident. And this activity could be as a result of turning in bed. It could be as a result of moving, coughing, feeding, defecation. It might be quite a number of things that could cause it. It usually occurs when the patient is otherwise relatively, when the patient's pain is relatively controlled and stable. And this is usually on opioids. So when we are talking about these kinds of pain, we are looking at patients who are already on opioids, and then their pain is stable, but then it comes as a result of an incident. Failure to control this pain can actually be very debilitating. So that's why we need to diagnose it early and be able to control it in time. How about end of dose failure pain? Anybody who can give it a try? Anybody to give it a try? End of dose failure pain? Should I select randomly? Muzi, would you like to try? Muzi, would you like to try? What is end of dose? Yes, Mercy. Go ahead to speak, Mercy.
I think end of dose failure refers to medication wearing off before the next regular dose is due.
Very good. Indeed, it is that kind of pain that will come before the next dose is due. So it is an indication that actually the medication, the concentration of this medication in the plasma is lowered, so the pain is coming back. Hope we are together. It occurs on a background of well-controlled pain. So usually the pain is well-controlled, but then this will occur just before the next dose is administered. It could be an hour or an hour before the next dose. It could be some minutes before the next dose, and then this pain will come. So we need to really recognize these two pains and the difference between incidental and end of life, end of dose failure pain. It is highly prevalent among patients with cancer. And that is because of the disease progression. As the disease continues to advance, you will expect that these kinds of pain will occur. And when they occur, then we know that actually there is a possibility that this patient is going to experience a lot of severe pain. And this pain is going to be very, very distressing, but also it will impair their functionality. So we need to really be mindful about that, because it will also affect their quality of life. So both pains may actually occur at any time of the day. There is no specific time. It could be in the night, it could be during the day, but it can occur at any time, and they increase. These pains increase high to a very high intensity, and this can go on for some time, for about 30 to 45 minutes, but it can actually be longer. Although this is what is documented in the books, but it can be longer. Diagnosis can only be appropriate if we know that we have titrated our morphine doses very well and the patient's pain has been stable. If the patient's pain has been unstable for some time, we cannot call these pains incidental or end of life dose failure, because we don't know what dose of the opioid is working for this patient. Okay, just to note that end of dose failure pain and incidental pains are actually called breakthrough pains. So anytime somebody talks about breakthrough pain, we are talking about these two pains. So in brief, breakthrough pains are actually a transient increase in pain, which is moderate to severe. Please note that this breakthrough pain, or what you're calling incidental pain or end of life pain, end of dose failure pain, are actually moderate to severe pain in intensity, and they occur against a background of pain that has been well controlled on opioids. Although we have initially talked about the two pains as incidental and end of dose failure pain as being breakthrough pain, we also have what we call the idiopathic pain. This is also a breakthrough pain. So anytime somebody talks about breakthrough pain, breakthrough doses, remember that we are talking about these three pains. Idiopathic pain occurs when a patient cannot tell actually what causes the pain. You know, sometimes you're making an assessment and the patient cannot tell you. They just tell you that the pain just comes. I also cannot tell what aggravates the pain. So that is usually what we call the idiopathic pain. How do these pains present? We need to be certain to understand the characteristics of these pains. Okay. They have a sudden onset, and you never know when they will be coming. And they are very severe. They are very severe. You never know when they are coming, and they are quite fast. Their pain really advances very fast. It's not a gradual increase, but it's very fast, and it lasts for about seconds or minutes. But it can, but it doesn't take so long, like saying 3 hours. It is usually a short-lived pain. But be mindful that even if this pain occurs, when this pain occurs, we need to manage it as early as possible, even if it is short-lived, because once we don't manage it, then the patient is going to really suffer too much. So it is often described as sharp or shooting in nature. How do we usually manage this pain? Has anybody of us managed this, come across this kind of pain in patients? Anybody who has come across this kind of pain in our patients? Are you there? Anybody who has come across this kind of pain in our patients? Sifiwe, would you like to share? Have you come across this kind of pain? End of dose failure pain or incidental pain?
Yes? Not yet. I had not been exposed to very much close to such clients. So I have not yet experienced that or be with a client who had suffered that kind of pain. Thank you.
Okay, thank you so much. Mercy? Mercy, have you come across such patients? Yes, anybody who has come across these kinds of patients, that just to share your experience? Yes, Zwane? Unmute and speak. Yes.
In our facility, they usually report that kind of pain when they have come for refills.
Okay. And how have you managed it?
We usually educate them that on how they should take the morphine with the NS8.
Okay. Thank you.
Yes.
Thank you very much for sharing. So just to go back, as I build on what Zwane has just shared, that remember, for us to diagnose this pain, we should have a baseline control of our pain. Our pain should be well controlled, and it just comes in between that well-controlled pain. So we know that dose. For example, if a patient is, say, taking 10 milligrams of morphine every 4 hours, and the pain comes in between, maybe comes 3 hours before the next dose, then we know actually this must be a breakthrough pain that we need to control because it has come before the next dose. So as we think of controlling this pain, one thing we need, these are a few things we need to think about. We need to follow the same principles of pain management. Here at Hospice Africa, Uganda, we have quite a very big file that has a detailed information on how to assess the different types of pains holistically, the physical, social, psychological, spiritual. So even when you're assessing the incidental pain, you need to still look at that holistically. But on the physical aspect, we need to remember the various areas to also assess. And what I have put there is just part of the physical, the way of assessing the physical part of the pain. So you need to look at the site of pain, duration, characteristic, when does it happen, what aggravates it. All those details need to be put into consideration. And then as we do this assessment, we need to note down the pain assessment in the diary. So if the patient, say, reports that, you see, in the morning, although I had taken my dose at 6, but before I took another dose, as I was waiting for, say, the 10 o'clock dose, pain came at around maybe 9. So you still need to note down what they did during that time. So throughout the 24 hours, we need to have a recording of our pain, and we need to use both the pharmacological and then the non-pharmacological approach to manage the pain. we need to reevaluate the kind of analgesia this patient comes. So like my friend has just shared about checking their NSAIDs and any other analgesia that they are on, so that you kind of get to know their efficacy and whether they are actually using them as recommended. We also need to consider the underlying triggers of this pain. What could have been caused? What could have caused this pain, and what is the underlying problem? Is it because this patient has a cancer? But if they had a cancer, the pain has been initially controlled. Then why is it coming in between? So you kind of assess for those details. And then we need to make sure that actually the analgesic that you are administering is being properly used. We have come across patients whom you will prescribe medications, and interestingly or sadly, they are not actually taking them as prescribed. They are taking them PRN. So we need to assess for all those areas. And we need to make sure that we are using adequate analgesics for the breakthrough pain. That is what we call the rescue dose. So we need to make sure that even when we are giving the rescue dose, we are giving sufficient quantities of these medicines that are needed for the pain. Because remember, the right dose is based on the patient's pain. And then we need to supplement the already existing regimen with a short-acting opioid, with a short-acting drug, because we need to see that we treat this pain fast. Remember, it comes very quickly and it is not going to last for a longer time. And if you delay, the severity will be too much and it will actually become difficult to control. So just to specifically highlight the specific things we need to do for each of these two pains, the incidental pain, we need to give a rescue dose, which should be short-acting. In this case, it could be an injectable, the parental medications, it could be injectable, it could be oral. In Uganda, we have used the oral preparations without really problems, although the parental could be faster when treating these kinds of pain. Remember that the rescue dose should be the equivalent of the dose used every 4 hours, or 5% to 10% of the total daily dose. Remember to record the daily dose in 24 hours in the diary, including the rescue dose administered. Why are we doing this recording? Because it is going to help us to titrate the opioid appropriately. Remember, for us to titrate the opioid appropriately, we need to know the total amount of the opioid taken in 24 hours. And then depending on the number of times you want to administer it, we can be able to divide that amount based on the number of times we want to administer. Okay? So maybe to kind of further reinforce this that I've been talking about, what would be the rescue dose if a patient takes a total of 30 milligrams of oral liquid morphine in 24 hours? Are we together? Are we still together?
Still with you.
We are together?
Yeah, we're together.
Okay. So, given what I have just been talking about, of say giving the same kind of dose every after 4 hours, what would be the rescue dose if a patient takes a total of 30 milligrams of oral liquid morphine in 24 hours? Anybody who would like to give it a try? This is mathematics. Mathematics, not very medical. Siblen, would you like to try? Sandazil, would you like to try? What would be the rescue dose? Yes, please. Anybody would like to try? Is this too hard a question? I'll take it back to my previous slide just for an assessment. I am saying that for you to be able to determine the dose, the rescue dose to give to this patient, it should be the equivalent of the dose used in every 4 hours, okay? Or it could be 5% to 10% of the total daily dose. Maybe the question I should start with before I go to the other one. If the person is doing taking 30 milligrams 24 hours, in 24 hours, how many milligrams will this person be taking in 4 hours? Maybe that's what I can start with. Anybody would like to try? Yeah? Yes, please. Anybody? Cyprian? What would be the dose taken in 24 hours? Sorry, that is taken every after 4 hours. Remember, each day has 24 hours. So if we have 24 hours and we are saying the patient is taking every after 4 hours, how many times of the day, how many times in 24 hours will this person need to take the medication? Yes, Mercy?
Yes. I'm not too sure about my answer, but probably
It's
the
okay.
client is going to take 6 doses a day,
Very good.
making it
6
5
doses. Very
grams
good.
per
Yes.
dose.
Okay, that is very good. So you're talking of 5 milligrams every
Yes.
after
And
4 hours. Correct. I strongly agree with you. So then, thank you so much, Mercy. So then, what do you think the rescue dose will be in this case for this patient?
Okay, I'm not sure if my calculations are correct, but if we are using the 5%, that will probably be a 1.5 milligrams. But if we are using 30, that would be a 3 milligrams.
Very good. I agree with you. So that could be it. And if you're using an equivalent of the same dose every after 4 hours, what would that be? If you're using an equivalent of the same dose, because remember you said you're going to give the patient 5 milligrams every after 4 hours. So that means at every time the patient is taking, the patient is going to take 5 milligrams. So what would be the rescue dose if you want to give the equivalent dose in 4 hours? Anybody who wants to try? Yes, Sandil? Oh, yes, 5 milligrams. Thank you very much. Sandil, thank you very much. So yes, the rescue dose, if you're giving an equivalent, would be a 5 milligram for this patient. So just to have that at the back of our mind, that for the breakthrough dose, you can give 5 milligrams, which is an equivalent of every after 4, the dose of every after 4 hourly. If you are giving maybe every after 6 hours, so you calculate based on that and you give that dose. If it's a 5%, it would be 1.5. If it's a 10% that you want to give, it's a 3, equals to 3 milligrams. In Uganda, we have found giving an equivalent dose of the same dose that they are taking very useful and very helpful. We have found the 5% and 10% being very low. But I must say that each patient is different. So depending on your assessment, you may want to give a smaller dose. you may want to give a higher dose. So depending on the assessment done, then you can determine the exact dose. Please note that because I have also noted some people will perhaps increase the dose. They will increase the dose of the opioid with hope that maybe the pain will go away. Please note that when you increase the dose, you actually are risking this patient to a number of side effects of the drug. So you end up actually giving overdosing them. So you should try as much as possible not to increase long-acting opioids, the dose of long-acting opioids when you're trying to increase that. When you're trying to increase to control this kind of pain. Okay, I hope we are all together. Okay, so let's go to the management of end of dose failure. We've been looking at the incident pain. Okay. So still similar to what happens when you're managing the incidental pain, you will need to give rescue doses because you cannot wait for the patient. I mean, you cannot wait for the next dose to occur while this patient is in pain. Remember, our aim is to make sure that the patient's pain is well controlled. Therefore, we should try to control it as much as possible. So give rescue doses as you wait for the next dose. And once the time for that next dose appears, you also give it. Record the daily dose, like I have talked about in the diary every time, because that will give us the exact dose we want to administer in the 24 hours. You can then consider increasing the total daily dose. And this is usually based on your calculation within the 24 hours. And the increase is usually 25% to 50%. Or you can actually reduce the dosing interval whenever possible. What do I mean by this? If you are giving, say, a long-acting drug of maybe a duration of every after 12 hours, you could consider giving it 8 hourly or 6 hourly or 4 hourly. So there you're reducing the interval, but best when you're using short-acting opioids. That's why I was asking about the availability of oral liquid morphine, because it's a short-acting opioid. And it is quite safe being oral as opposed to the parental opioids. Consider using adjuvants, and this could be antidepressants or anticonvulsants. But it doesn't mean that this will work immediately, but adding them to that can be very helpful. You can also apply the non-pharmacological measures, and this could include educating the patient about this incidental pain. So when you're talking about it, you're saying that this pain will occur, and once it occurs, please give this kind of medication in this manner, based on what you'll have trained and your assessment. Encourage relaxation techniques. So as I conclude, we need to know that incidental and end of dose failure pain are common. They are very common, not only in cancer patients, and these must be assessed and managed at all times. Increasing the dose of long-acting opioids in this case often exposes patients to needless side effects of the drug. Essentially, stop short-acting opioids must be the drug of choice in managing breakthrough pain. But also, we need to know that treating should be individualized based on the patient's incidental or breakthrough pain. We are not managing as a uniform thing, but it is based on each individual's presentation. Thank you very much. Do we have any questions? Yes, Cyprian. Yes, Cyprian.
Yeah, please help me, Tim. How did you come up with the 5 milligrams? Because I thought maybe I would divide 30 milligram by 4 hours to get the 5 milligram. But me myself, I did get 7.5. So it's like I'm confused as how did you come up with the 5 milligram as an end of dose? What do you call it? as a
Okay,
rescue dose.
thank you so much. I'll take that question up and take another one, and then I can respond to them at once. Thank you so much. Another one, Sifiwe. Yes, I would like your question, please, Sifiwe.
Okay, thank you. Yeah, mine is just a concern. You will just summarize it earlier. Thank you for such a wonderful presentation. And also, I'm looking at that we need to ensure that we document all the doses, especially with the times and the frequency of when and how many are we giving that client. Since we have moved these initiatives to be a little bit more sustainable, hence they are most of these clients are seen in the community, which we somehow do it as we move from facility to visit these clients in their communities at home. I'm more concerned on how do we take care of the clients' information systems. If we are having a file, is it going with the health practitioners who come to visit, or are we keeping that file with the client? If we are keeping it with the client, which is what I wish we can do, so that we can improve continuity of care, which will then means any healthcare worker who is available at the moment can go and visit the client and find full information on how the dosing and the frequency was calculated, and how much is the client taking, why were there any adjustments if they were, so that we have a full understanding. But I'm also concerned about the safety of the client information as well. In your communities, how are you managing this client information? Thank you.
Thank you very much. These are really very valid questions. Let me first respond to these two before I can take another one. Is that Cyprian? Do you have another hand again? Okay, please speak if you want to speak before I can respond to it. Oh, this is no Pomelo. Let me respond to this first two, and then I'll get back to you, no Pomelo. Okay. So to start with Cyprian, the question of how we got the 5 milligrams, Cyprian did a very good calculation. Perhaps he can help us tell us how did he get the calculation before I respond to it. So it was Sandil, I think, who did the calculation. Would you like to share with us how you got that?
Okay. If the daily dose is 30, and then morphine is given 4 hourly, so that means 4 hourly in a 24-hour is 6 times. So then the 6 times divided by the 30 daily dose, you will get the 5.
Very good. Thank you so much. Cyprian, is that any clear? Cyprian, is that clearer?
Okay, she's saying 4 hours. He has to administer the dose every 4 hours, isn't it? In 24 hours.
Thank you. So what we are saying is you have your whole day that has 24 hours, okay? So these 24 hours, we are saying we are giving morphine every after 4 hours. So how many times then will this morphine be administered? So you divide 24 by 4 to get 6 times, okay? So that means you're going to give your morphine 6 times, okay? 6 times a day. But remember, we are saying that a patient takes 30 milligrams in 24 hours, okay? So we need to divide these 30 milligrams by the number of times we are going to give the morphine, so that we know at each time You get it? At each time, this is the amount you're giving. So 30 divided by 6, you get 5. So that means you're going to give 5 milligrams of morphine every time you're giving. Are we together?
Yes, thank you so much.
So just to note that at night, we give a double dose because we don't want to wake up the patient in the night to take the last dose, say at around 2 a.m. So we usually give a double dose. So in this case, we'd give 10 milligrams so that the patient can sleep, say up to 6, and then can be able to take another dose at 6. Okay. So then I get to the second question of Simfi about his concern on the management of data while in the community, safety of the patient's data. So sharing the experience of what we do here in Uganda is most of our work, most of our patients are in the community, just like yours. And morphine is available, can actually be accessed by these patients, and they can stay with it for even a month. So we'll give them, usually the standard would be, say, 2 weeks, but they can actually be with it for 2 months. Sometimes patients are coming from longer distances, so we might even be able to extend it longer so that we don't cause more distress for them as they come to collect medication. So what do we then do? We provide them with a medication chart and an appointment date. And there are also contacts on that chart. So every medication that you give on that card, you will need to document it, document when you gave it, how is it prescribed, how is the patient going to take it. And when you stop it, you also document when you stopped and why you stopped it. So that really helps us to follow. But interestingly, also these patients are very clever. So they will also even have this information, this list of medication. Sometimes they write it in their books. Sometimes they're able to verbalize it and they're able to report to you that this is the kind of medicine that I am using. So every time it is the responsibility of any healthcare worker who goes in to assess what previous medications this patient has been on and see how to support them. Just like when they come to the health facility, you'll ask them that record. So that's how we've been able to manage the patient's data and ensure safety. And because we have a shorter duration of their review, it's easier for us to be able to follow them up on how they are using in the community. I hope that answers your question.
Yes, thank you.
You're welcome. Okay. Somebody's mentioned, there was a question that was there. Somebody's asking, oh, this is Nomatemba. Okay, thank you, Diana. 5 milligrams is equivalent to 1 daily. Then he says, I think Eswatini palliative care services differ in a way, so we might not be able to adjust dosing at any time. Stand to be corrected as I am new in this course. Thank you so much for sharing. And as I said earlier, that we are learning from each other. So perhaps giving me or sharing some insights on how you usually dose your medication might be very insightful. So Nomatemba, would you like to share? And maybe we can learn from that or see how we can adapt to each area, because definitely each country is different, each setting is different, but we can borrow examples of what others are doing and see how we can incorporate that in our practice. I don't know if we have more time for that, but Sandil, you can guide. Could he be able to share that, or just for clarity?
Thank you so much, Diana, for that, and thank you so much, Nomatemba, for the question. What I can say is that currently the country is running in 2 different platforms of documentation. There is the integrated system, the HMI, also CMIS system, which help us to track and know what has happened with the patient. But for those who don't have HMIS, we normally recommend that anytime you are going to adjust the patient dose, let it be documented. But then if you are not sure on how to do it, is the best way to refer the patient or call the immediate doctor who prescribed the prescription so that then you can adjust the pain. Otherwise, it is not okay to leave the patient languishing in pain because you cannot adjust the dose. But then that's why we are here today, to learn together how best you can do it. But the critical thing is it's proper documentation. Sometimes as hospice at home, we provide the home-based palliative care, and we find these patients prescribed with morphine, but then you find that it's either they're not taking it very well or they are taking it very well, but then they are experiencing these breakthrough pains that are not managed well. Then what we need to do then is to initiate them on breakthrough pain so that the doses, so they can be able to control that pain. But then that must be documented on the patient file or patient document that is with the patient. Normally, patients who are given morphine in the country, they are also given some documentation files. We call them prescription forms in our country. So they do have them. So it's better that you document there, even the rationale for that adjustment on the dose. When they go back for refill to their next facility, then they go with that file. If then you are able to know the palliative care unit, like we have RFM, Babane, Shatikulu, you can call them and then discuss on the issue of the rescue dose or any dose adjustment at the community center, other than to leave the patient in an uncontrolled pain. Thank you.
Thank you very much, Sandil, for that supplement. And it's really good to know about what is happening. Interestingly, it's not very different from the system here in Uganda. We also have the HMI system for our record purposes, and that is usually in the government health facilities. But over the years, we have advocated that all health institutions that are seeing patients who need palliative care also have this kind of system. So this has been also taken to other grassroots health facilities and NGOs providing palliative care. And this data is now being incorporated into the general country healthcare system. And we are slowly reviewing the data because initially it was palliative care was not included in this system, but this data has been incorporated. So perhaps as time goes on, you could be able also to advocate for it to get into the HMI system. About the documentation, that is very, very key, because honestly, without documentation, there is no work done, and it becomes difficult for me as a healthcare worker to come and follow up what you have done. In Uganda, we are quite privileged that nurses are now, trained nurses in palliative care are now allowed to prescribe morphine or opioids, and this has kind of increased the number of professionals that can be able to support patients in pain. So even while in the community, it is easier to follow up. So that has kind of helped to relieve the so much burden that would be on the doctors, and they can the drug can reach so many patients in the community. So yes, thank you very much for that insightful information. I don't know whether we still have time really to take on more questions. Sandil? Do we still have more time?
I saw Nombumelere raising a hand before. I don't know if she has something to ask before then we move to a case presentation.
Okay.
Yes,
Yes, please.
Can
Thank you very much, Diana, for the session. My question was on management of the incident pain. Will I,
yes,
after assessment, will I be wrong or right by attending to the incident pain before the incident, like changing the dressing or changing the position? I administer the opioid before, then I change the position. Will it be okay?
Thank you. Thank you. You have raised a very important pain. When dealing with incident pain, it is something I didn't really, I think, talk about, but you have a very valid point that we need to anticipate, because remember, you're going to carry out a procedure or something is going, an activity is going to happen. So most likely, you know that the pain will occur. So we need to anticipate this pain and take the preventative mode by administering the medication at least 30 minutes or an hour before this pain, this incident happens. That will help to minimize the pain that the patient will have got. Because if you administer after the incident, then this will cause a lot of psychological trauma, and the patient may never want to do that procedure again. So all in all, we need to prevent, give the preventative medication before you do the procedure. Thank you very much.
Thank you. Thank you so much, Diana. You know, I hope the team has learned a lot today. I don't know, but we still to have some few months under this theme and to discuss more on pain. Thank you so much for your time and dedicating to be with us. Indeed, it's a great team. Actually, here you are seeing people from different areas of the country who are dedicated to provide palliative care. We are hoping when this team are together working, all those things that need to be changed in terms of caring of these people will be changed, because everybody will be understanding the needs of patients, especially our palliative care patients, who are sometimes left alone to suffer in pain. And that's the goal of this session, is to help us share the experiences, so that even if I'm not a palliative care nurse, I'm seeing people from SRH here who have not been used to dealing with patients with palliative care. But now I'm sure from the lesson that we are getting here, they will be able to do something when they meet those patients in their departments and in their workplaces. Thank you so much. Maybe for this time, may I give this chance to RFM Hospital to present your case for today. And kindly note, colleagues, that RFM in our previous session, they were supposed to present the case, but they couldn't make it due to other commitments. So we have requested them today to come again today and represent the case, so that you can ask, you can comment to them, and they can be able to improve in whatever they're doing. Ziggy and team at Zinhle, can I give you this chance to present the case? Are you okay?
Hello.
Yes, are you okay?
Yes, I'm okay.
Okay. I'm still trying here. The gadget I was using locked off, so let me try and give it some rights. Diana, would you allow and give me the hosting rights now, all of them?
Sure. Sure. Let me do that now.
Yes.
Thank you. Gosh.
A little
Just
bit.
a minute.
Okay.
Just a minute. Okay.
Yes.
First. Okay, that's it.
Thank you. Yes, so I will be sharing the screen very soon, Zwane. I hope you can see it now, Zwane. I hope you can see it now. Zinhle?
Clear. I can see it.
Okay. You can go ahead, Zinhle. Can I put the first page for you? Hello, Zinhle. Hello, Zinhle. I think they've been lost again. I don't know, maybe they will be back very soon. I'm hoping so. We've just lost them now. But maybe to continue, because I'm sure they will be back and comment. This was their case that they presented last session. They have a patient, a 29-year-old male who was diagnosed with chronic rectal ulcer. And the patient main problem was the patient is having chronic severe pain on the lower back. And when they were doing the checking the complaint, and then it was pain on the lower back with a score of, okay. Zinhle, are you here now? Okay, you can continue. Yes, you can continue.
Zinhle is not well at the moment. I will present on behalf of her.
Okay.
On her behalf.
Okay.
Yeah.
Yeah.
Okay, my name is Nonsikela Lontuli, palliative care nurse from RFM Hospital, Eswatini. My case is a 29-year-old male with chronic rectal ulcer. His main problem or concern, patient is having chronic severe pain on lower back. Chief complaint of severe pain on lower back, pain score, it's 8/10. Comprehensive assessment of pain, of present pain. Pain is somatic, it radiates, and specific relieving factors, it's pain medication, functional impact of pain, it affects the patient's mobility, sitting and sleep. Current analgesics, strong opioids. Medication effectiveness, it's complete. Physical assessment, aspect assessment, patient in severe pain cannot sit properly and relax on a chair because of pain, talks loud enough and clear, neat, ambulates well, no pallor and dehydration. Psychological aspect assessment, fully conscious, well-oriented to time, place, and person. Social aspect assessment, patient is ambulating, education, tertiary school, he was trained on carpentry. He is a self-employed carpenter. Socioeconomic class, middle class, marital status, single, lifestyle habits, stop taking alcohol and doesn't smoke. Relevant health condition in the close family members, there is none. Other social related information. Patient is from a family of 5 children. He stays alone at Fairview and with mom at home. Have a 15-month-old baby. Spiritual aspect. He is a Christian and goes to the Nazarene church. He loves reading the Bible and praying. Significant medical surgical history. Patient is a known outpatient on treatment. He developed hemorrhoids 2019 and was done colostomy June 2021. He also did biopsy June 2021 and results revealed that there was no malignancy. He was having a septic wound in between buttocks that made doctors to prescribe antibiotics for him. He was enrolled on palliative care at RFM 16 September 2021. He was complaining of severe pain on lower abdomen and back. Pain score 9/10. He had a brownish mucus discharge from rectum. He needed colostomy bags and pain medication. He was using tramadol, paracodaine, and diclofenac for pain relief. Tramadol was no longer effective in relieving his pain, and he was changed to morphine tablets since syrup was out of stock. He is still using morphine tablets, paracetamol, and bisacodyl for pain. He is currently refilling colostomy bags, ART, and pain medication at RFM. Medication, he was taking tramadol 50 milligrams orally 3 times a day, paracodaine 1 gram orally 3 times a day, bisacodyl 10 milligrams orally once a day, ciprofloxacin 500 milligrams orally 2 times a day for 7 days. Current medication is morphine 30 milligrams orally 2 times a day, paracetamol 1 gram orally 3 times a day, bisacodyl 10 milligrams orally once daily, and AZT 3TC 2 times a day, and DTG once daily. Advanced care planning. Do not resuscitate orders not yet discussed with the patient. There is no living will. Advanced decision to refuse treatment. It has not been discussed with the patient. Healthcare proxy is his mother. Mental capacity, it was assessed and the client is mentally stable. No consent or comment at the moment. In vital signs, temperature 36.1 degrees. BP, it's 129/73 millimeters of mercury. Pulse 116 beats per minute. Respirations 18 breaths per minute, and the oxygen saturation is 98%. ECOG functionality is 1. Other symptoms, pain, it's severe. There is no dyspnea. There is patient is anxious. He's a bit agitated. No depression, no drowsiness, no nausea and vomiting, no anorexia, no constipation, no dry mouth. Mobility, it's there, but not quite well. Focused investigation. Since client is on ART, he has done a viral load test and he was found to be suppressed. The viral load was found to be suppressed. Further care plan, patient is currently refilling his medication and colostomy bags at RFM. He wishes to reverse the colostomy because getting the colostomy bags is now a problem and his wound have healed but still have severe pain. RFM will continue monitoring the client's wellness. Thank you.
Thank you so much, Nduli, to present the case for today. I don't know what the team can say. May I give you the opportunity, colleagues, to comment on the patient? or to ask Nduli or to add something or advice on how best they can manage this client that they are seeing currently in their facility. I will give you the opportunity to comment. Anyone who wants to comment, add or ask anything from the RFN team, or to add on what they are currently doing to best manage this patient. Yes, I will start with Cyprian, then go to Diana. Cyprian, can you comment?
Thank you, Nduli, for the presentation. I think for me, it's well taken care of, but please add some seat pads there. I think the client can benefit to do MR seat pads maybe twice a day to reduce the odor and to fasten the healing of the wound in the buttocks. That's my contribution. Thank you.
Thank you. Thank you.
Thank you, Mr. Matemba.
Yes. Diana?
Thank you very much for this case, which we can learn from. So maybe something I might have missed, but for clarity, what could be the possible cause of this chronic rectal ulcer? And from the time of our intervention as with the healthcare workers, what effect has our management had on this patient?
Thank you, Diana, for that question. Anyone who may respond? I don't know if you have something to add on what Diana is asking concerning the etiology of the problem the patient is going through.
Yeah. What is the cause of the ulcer? And then in relation to our interventions, from the time we started seeing this patient, what has been the effect of our management on this patient?
Thank you. I hope, have you get it, Nduli?
Okay, the cause of the condition is still confusing, since the patient said he did biopsy and it was found that he doesn't have cancer. And through on his palliative care journey, he also tried to use some herbs, and we could see that there is a improvement on the wound. We can't state exactly what really is the cause. Currently, the wound is now closed. I may say that. At the moment, not currently.
Thank you. Thank you, Nduli. I don't know if Diana, you get the clarity.
Yes, I have got that. Thank you so much. But that makes me also wonder, because this is a similar case to what we see here, and it's not really so different. So when I was asking about the possible cause, is to try and understand what likely investigations have been done other than the biopsy, whether there's been a possibility of colonoscopy, and whether actually this patient is in denial of the diagnosis, but also clinically, we as healthcare workers, what we think the actual diagnosis could be, because it is what helps us to intervene even when we are not very definite on the exact cause. So depending on our clinical diagnosis, that could help us understand, because for us in Uganda, many times patients have come in and we don't know the diagnosis, but we treat blindly until we kind of come to an agreement, both the patient and the carer, to agree on what the diagnosis is and the cause. So are there other investigations that have been done, say colonoscopy, just to help with the diagnosis?
Maybe if any that has been done more than the biopsy.
No, we didn't do any other test in RFM. Maybe where he was done the colostomy, they did the other investigations.
Okay. Okay. Thank you very much. I don't want to dominate so many questions, but I'll ask one more just to try and understand what our goal of care is in this case.
Okay. Yes, that one is key. Oh yes, thank you so much, Diana. Yes, you go ahead, Julie.
The goal of management is to relieve pain.
Okay.
Okay.
Thank you.
Thank you. I don't know if anyone wants to comment. Okay, Pumelelo.
Thank you very much, Mr. Mata. My first comment is, I saw that the patient was diagnosed with hemorrhoids in 2021. Is there anything that we have done to follow up on that one? Because we may find that the ulcer originated from those hemorrhoids. And the other thing I wanted to see was, have we done anything to deal with other pains, not related to the physical pain that we normally assess from the patient, such as spiritual pain, psychosocial, and other things? Because I saw that the patient has a 15-month-old child. Where is the mother? Where does the child stay? Because when I look at the way we are handling the patient, it is like we are attending to that pain related to the physical side of it. Like when it comes for refill, for other refill and the other medication. And the last question is, how often does the patient come to RFM? How often have we visited the patient at his or home? And have we ever taught him anything relating to Mr. who talked about 6 parts? Any health education that we have provided to him that would help is that the pain, besides the medication refill. Yeah, I think that's all.
Thank you. I don't know if you were able to get the comments and questions from Nompumelelo Zinhle, Nduli.
Thank you so much, Nompumelelo, for your questions. They are really enlightening me. It's been just talking now.
Okay.
We really have a challenge with this patient because mostly the patient is being seen at Mbabane Government Hospital. In our facility, only comes for pain management. And we are trying to get all the information, but the patient mostly is not forthcoming with all the information. we tried to ask about, because in previous visits, the mother of the child would come for the refills of the patient. And we will try to ask about the patient, but they are really not forthcoming about what, because previously we thought she was his wife until recently. He told us that he's only a girlfriend. So it's just that challenging. And recently the patient is being followed at Mbabane government because he wants to reverse the colostomy because of the bags. They are really expensive. So that's what I can say. I don't know if I answered your question.
Okay. Thank you. I don't know if Napumele is satisfied.
And another thing, we don't do home visits as RFM recently. We just an outpatient department.
Okay, thank you. I think Boom is a follow-up on that.
I would suggest that we do a proper referral to Mbabane, so that we don't leave the patient hanging between RFM and Mbabane. Because you would come to RFM and say that some other things are taken care of at Mbabane, and when you go to Mbabane, we'll say the same thing about RFM, then other issues will be left hanging. Looking at the side at which the answer is, his self-esteem is also compromised. So I would suggest that we make a proper referral and maybe do a follow-up to make sure that he is taken care of at Mbabane, so that they also attend to his other types of pain, and they make sure that they visit him at home, because most of the issues that pertain to someone's privacy will be taken care of in his or her home. Yeah, thank you.
Thank you so much, and thank you so much, RFM, to bring more clarity. I think indeed we have done justice to bring this patient in this forum so that we can all share. Diana, do you have something to add?
Yes, I'd like to add to what the previous speaker has just mentioned. The importance of following up with other service providers. I think, as I noted, the different issues affecting this patient, AZT looks like this patient is an HIV positive patient, if I'm right. And I'm wondering what the relationship of the palliative care team is with the primary physician of this patient, because it's important for us to collaborate and work together with other care providers. So even if the patient is not open, the fact that initially he has given us a little hint of some areas or where he's getting healthcare services from, we need now to start touching base with these care providers to understand his care plan with the different service providers. Otherwise, we might be working on something that, and they're also working on something different, and we're not coordinating the care, which could also impact on the well-being of the patient.
Yeah. Thank you, Diana, for that. I also wanted to add, I hope RFM you are getting what the team is sharing with you. I also wanted to say that even at hospice, you can link the patient with us. You know, we have a social worker, we have a nurse, and sometimes we do have the colostomy bags. So you will find that the patient will benefit from that, while hospice will also be able to reach the patient on the other psychological and social aspect at his home. So I can say that another link you can do, but then you need to discuss first with the patient in terms of, will the patient appreciate a visit from hospice? I think there are other resources like the colostomy. We do have access to them from government. When we order, sometimes we get. Sometimes if we have not get the order, sometimes we procure them from our side for the patient. So you find that we are able to give them a certain amount of colostomic bag to last them for a certain period, which can supplement the others. And, you know, this is a man sometimes going to hospital, they will feel not comfortable. So I think linking them also with hospice will alleviate the load on your side to see how best you can do it. Last time I added that one of the things I noted here is the history of hemorrhoids and then the prescriptions in terms of the opioids together with the laxatives. I will recommend, we have noticed that most of, especially patients who have cervical cancer who live a little bit longer on opioids, you discover that when they are given opioids, we need to advocate that opioids should be in dual effect, in terms of stimulated and stool softeners, because you find that when they are taking these opioids, the bisacodyl will push the hard stool through, but then it will lead to the hemorrhoid itself. So I will recommend that in our different facilities, whenever we are prescribing an opioid, let's always put a stool softener on that. If it's not in our stock, let's encourage the patient to get this castor oil or liquid paraffin or the lactulose, so that it softens the stool, so that when then the bisacodyl is pushing through the gut system, it pushes through in a soft way, because we discover that most of them, they end up developing the pad. So I think in our patient, we need to look at that. For this one that is already having the history, you will find that he will constantly come back for those issues. So we need to recommend looking around those issues. I know sometimes the issues of funds in our government system and our facilities is not easy, but we need to discover with the patient the importance of such laxatives when combined with the opioids. They help to prevent such complications. Otherwise, I will say thank you so much, RFM, to share such an insight and such a patient. You know, males, especially in our African context, they are not good medical care seeking people. So we need to take care of them whenever they've presented in our facilities. Let's manipulate all the resources that we have around us. I'm happy that now we have people who are working on the HIV/TB side. We have people working on the SRH side. Now they'll be able to identify patients who need palliative care and link them as quick as possible. So we also link with them. So we are working together to improve the quality. The goal that we have at the end of the day is to improve quality of life and improve the comfort. Thank you so much, team, to join us in this session and to have us this far. And thank you so much, Diana, to offer your time with us. And may God bless you. And we wish to have you in next sessions. In our next session, it will be held on the 11th of October. We will be discussing neuropathic pain management in palliative care. And we are hoping we will be having another guest from Hospice Africa. So let's invite some of our colleagues, our doctors, to join us as nurses, because today I know most of us here are nurses. Let's invite them so that we can share together the information. Have a nice day. Before maybe you exit, kindly click on this feedback link we have shared with you, so you can share with us on how best we can improve our session. Thank you. Bye-bye. See you on the 11th of October.
Thank you very much, and bye-bye.